Hi everyone, hope you're doing okay. Welcome to this next episode of Two Doctors Chat Menopause. Carys and I are going how we can use treatment to help manage them, and some of the lifestyle factors involved. So I'm just waiting for Carys to join now, so hopefully she'll be here in the next couple of minutes. Hope you've been having a good week, whatever you've been up to. I know had some nice weather here. It's been lovely and autumnal this week. So I hope it's been the same for you. Yeah, really looking forward to chatting about migraine. It's a really common presentation that we see in perimenopause. And we'll go into reasons why, I'm sure when Carys gets here. Hope she is managing tech okay. I think I've sent, she says she's unable to join. I'll just send it again now. Hopefully that won't be long.
Hi, Rachael.
You might be there, Carys.
Sorry, there was a slight blip. I'm not sure quite what was happening. How are
No problem
you?
at all. Yes, I'm really good, thank you. I was just saying we've had some really nice autumnal weather again this week, which has been really nice.
Yes,
So
yeah.
yes, what about you? How's
Today's
your week been?
yeah, it's been really good. This week's been really good. So the thing I did that was a bit different was go and see 1984, which was
Mm.
at the local theatre, which was really interesting. So yeah, a
Mm.
lot of very thought-provoking and excellent actors. So yeah, really, really good. So today we are talking about migraine or
Yeah.
migraine and migraine attacks, aren't we? So we
Yes,
just
yes. I
so we
was just saying
get
it's
it
a
right
really
with.
common
Mm,
presentation in perimenopause. That's something we see a lot of. Um, just before you joined. Um, I think there's a little bit of a delay, so I hope you can hear me all right. I hope the sound quality is okay.
yeah, I can hear you fine. Are you okay? Can you hear me?
Yeah, I think it seems a little bit better now. But yes, there's lots to cover, isn't there, in terms of migraine and perimenopause and the different things that sort of can be helpful.
Yeah, absolutely. So I think if migraine affects 20% of women, it's really interesting, isn't it, that many people, I think, in my experience, don't understand it or maybe don't quite know that they've got
Mm,
it or don't treat it effectively, and maybe don't understand what an aura is.
mm,
So today we're going to go through those sorts of things, aren't they? So that the three questions I think are helpful when we talk about what is migraine. So has a headache, I'll read them from here, has a headache limited your activities for a day or more in the last 3 months? Do you feel nauseous or sick to the stomach when you have your headache? And does light bother you when you have your headache? And if you answer yes to two of those questions, that's 81% predictive as a positive diagnosis of migraine. And if you answer yes to three of them, that's over 90%
mm.
predictive. So it's really interesting, isn't it? So what does migraine involve?
Um,
How do
so
how
there's
do we
obviously,
split it up?
yeah. So there's obviously a lot of individual sort of variation, but I suppose we talk about um, the prodrome, which is the time before the headache arrives. Then you have the sort of aura for some people, which may or may not arrive. Then you have the headache, and then you have the postdromal phase. That's the time after the headache. And I think lots of people don't fully recognize that actually the migraine isn't just that time when you have the headache. You can go on for quite some time and can be quite drawn out, and that obviously impacts, doesn't it, on the sort of impact of day-to-day life and activities and being able to go to work and things. And so the prodrome is the time before. Not everyone will be aware of their sort of prodrome, that's sort of the pre-symptoms. But some people might get, they might feel very hungry, very thirsty. Some people sort of go to pass urine a bit more frequently, might be yawning, craving certain foods. They might see changes in their mood, be more irritable or low. And then you may get the aura, which I always say is a little bit of a sort of a warning sign. So often sort of defined symptoms that people get that last sort of between 5 minutes and 60 minutes before the onset of the headache. Usually that might involve visual symptoms, so change in vision that affects both eyes, usually flickering lights. Some people, they feel a bit sort of confused and not quite themselves with
They
that.
might
It can
do
be sort of very,
this.
very,
That's one of those
yeah,
things,
lots of
isn't it? Yeah.
flickering, yeah.
Yeah.
Or yes, lots of zigzag lines is quite common. Can affect speech sometimes. And then the headache starts, and the headache can be often be associated with nausea, vomiting, like we said. Often people just say they have to go and lie down in a dark room. Usually a one-sided headache, throbbing,
Yeah.
can be quite, moderate to severe. If you've ever had a migraine, often really sort of really significant, can't it?
Yeah.
And often people can't really function. I know if I have a migraine, I can't do it. That's it. You just have to go and lie down. There's no choice about it.
No.
And often you can be repeatedly sort of vomiting. And then afterwards, once the headache settles, you can have this period, sometimes it lasts hours, sometimes up to days, where some people just feel like they've got brain fog, confused, very tired. Their mood might be affected while sort of recovering from that. So it can, sometimes it can just last for a few hours. The headache, sometimes it can go up to sort of 3 days for some people, and you've got this time beforehand and time afterwards. We're looking at the best part of a week sometimes, overall, before you're back to full functioning.
It's really interesting, isn't it,
Mm.
to think that maybe 20% of us have this, and it can last for so long, and be so impactful for our lives and for work and relationships and things
Mm.
like that. So it's a spectrum, isn't it? Sometimes people don't get so much. When I get my first migraine was actually in perimenopause, and it just was this pain here, right in the corner of my eye I'd never had before, brought on by computer work. So that brings us um, to triggers, doesn't it? So what are our triggers? So things that may bring one on for us. I think it's all different for everyone. So it could be a change in routine. Say you're about to go on holiday and you're getting up early, and you haven't had the sleep that you're usually getting. Could it be that you're very stressed? So some patients I have a very stressful time at work, and that could bring on a migraine. What about missing meals? So those people who are intermittently fasting, we don't think that's going to be very good for people who have
No.
migraine attacks, because you need to make sure that you're having regular meal times and maybe snacks in between to keep your blood sugar stable. Time at the computer, change in weather, dehydration. Exercise can bring migraine attacks on for some people, and actually regular exercise can help keep them at bay for others. So we think sort of migraine tends to get better as we get older. It's a spectrum, with some people getting mild attacks and other people getting really severe long attacks taking them a week. And it's not just a headache, it's the whole body that can be
Yes.
involved, which is really tricky. So what is, and this is the thing when I spoke and learned a lot about this is the thing, acute treatment. So when it comes on, what do we do? Because I think many of my patients don't take treatment soon enough. They try and wait it out, because we all have busy lives, don't we? So 20% of us may have an aura, so we know it's coming. So but actually 80% of people don't have an aura, so they will just start with the headache. So when do we take the medication, and what is best? And let's go with that
Yeah.
next.
So I usually suggest taking the medication as soon, well, I suppose there's a couple of different types of medication, aren't there?
Yeah.
But as soon as people start to get those sort of symptoms of um, aura, and sort of feeling like the headache is coming on, I usually recommend taking the sort of anti-inflammatory treatment if people can take that, or paracetamol. The advice is to take that with a small can of fizzy drink, because what's happening with the rest of the body is that the sort of gut transit is slowing down. So in the same, you can't absorb or digest the tablets as well as you normally would, and I suppose that's partly what contributes to the nausea and the vomiting as well. So you want to be able to get something on board, get it digested before you start,
Mm-hmm.
being sick and not keeping anything down. And then there's also, we have some other medications called triptans, that's recommended that you take as soon as the headache comes on. We're
Mm-hmm.
wanting to sort of start those as soon as possible, not waiting for the headache to sort of get worse. And if they're going to work, they usually work pretty quickly. You can take them again after a couple of hours, but you don't want to be taking them if they've not been effective. There's also some other options instead of tablets, like the nasal spray, which can work quite well if somebody's vomiting a lot as well, and also the some tablets that you can dissolve as well rather than taking them, which can work better if people are being sick. So yes, I think sort of getting that initial treatment on board really quickly can make a big difference. But like you say, I think because sometimes some of the symptoms are a little bit non-specific, often it's easy to think, oh, this might pass, or so. Getting it on board really quickly is
The best thing
really
was say
important.
to
Yeah,
hit the migraine and don't let it hit you.
yeah,
So the soluble anti-inflammatories are quite good, aren't they? 600 to 900 milligrams of soluble aspirin can be helpful, or soluble paracetamol or mefenamic acid. And then an anti-sickness tablet, even if you don't feel sick, just to help with the motility of the gut. And those should be taken regularly through the attack, not just at the beginning.
yeah,
And then the triptans, so 7 different triptans, which is really interesting, isn't it? There's a wonderful Heads Up podcast that talks about the different triptans, and you can try ones to see which works best for you. If you've got menstrual migraine that comes on just through your period each month, then there is a triptan called fomatriptan that can be used just a couple of days beforehand and for 3 days during your migraine, in order to try and help reduce that severity as well. And interestingly, it talked, the reading I was doing talked about not taking the acute medication for too many days of the calendar month. So making sure it's not more than 10 days, so that you're not actually bringing on a medication-induced headache, which is different from a migraine, which is
yeah.
actually caused strangely by the painkillers that you are taking to relieve the pain of the migraine. So that's really interesting. What about preventer treatment? So if somebody's having lots of migraine attacks, we've got different treatments, haven't we, that can be used to stop them coming. So you've got your
Yeah.
acute treatment, you look at your triggers, you look at those sort of, we have some prescribable treatments, don't we, if someone's getting a lot of migraine attacks?
Um, yes. So I suppose that comes down to partly understanding what's going on in terms of the pattern of those people's migraines. Because if it's hormonal, then we might want to manage it slightly differently. I suppose we can come on to that. But say, for example, someone's been having regular migraines through their life. They don't seem to be particularly hormonal. They're just sort of happening. Maybe stress is a big trigger, for example, or other things. Then we can use medications like beta blockers, which someone would take every day, and they can work really well at reducing the frequency of migraines. Sometimes we need to build up the dose over time, so it can take a little bit of time. But I've seen those work really, really well. There's some other blood pressure tablets called candesartan, which we were not
I've
using in this
seen
instance
those.
for blood pressure.
Yeah,
And I've had really good
really good.
results with those when they've
Me
been
too.
started.
Mm.
But obviously, we have to keep an eye on people's blood pressure to check it's not dropping too low, for example. And then there's some other medications that sort of I know the neurologists sometimes use. There's one called topiramate, which can have a few side effects and can cause complications if somebody's pregnant, for example. So needs to be used a little bit more cautiously. And then there's some of the newer medications, aren't there? The CGRP antagonists, which tend to need to be prescribed by the specialists, don't they? And there's some, I don't know about in your area on the NHS, but there's some sort of stipulations that people need to have sort of tried other medications first that haven't worked. But I think there's brilliant results with those from what I'm seeing. So for people that have really struggled, they are a really useful and new option that potentially we'll see more of being used in the future.
There's a lot of different types of preventive treatment. So that's always the third thing I think of. So you've got your triggers, you've got your headache diary, you've got your acute attacks, and then you've got your preventive treatments. And then now what we really want to talk a bit more about is what happens in perimenopause. So we know sometimes people who have menstrual migraine, so migraine can be change as estrogen changes. So we're looking at, so estrogen withdrawal can often trigger a migraine without aura. And migraine with aura can be triggered by a spike in estrogen. So I suppose around ovulation, as you have your spike in estrogen, you may start to get, maybe if you're someone who suffers from migraine with aura and you have the right, so that therefore your right conditions and you've got the trigger, then that could happen to you then. And in perimenopause, of course, there are spikes and troughs all the time, aren't there? So so people often will think, well, we know that in migraine with aura, we can't give the combined contraceptive pill because of the risk of ischemic stroke, but we can use the combined contraceptive pill in somebody who doesn't have migraine with aura if we have that discussion about risk and benefit in order to stabilize things out. And that can sometimes be really helpful for menstrual migraine. But actually in menopause, in perimenopause, there are certain things, aren't there, that work better. What sort of HRT do you think do we use in somebody with migraine with aura or in migraine without aura in order to help with their perimenopausal symptoms?
Yes, I use a lot of patches. So if we're talking about estrogen and we're thinking about those peaks and troughs and the fluctuations triggering migraine for lots of women, if we can offer some additional estrogen in the form of a patch, so giving a really steady level, can help just to sort of buffer some of those peaks and troughs. Sometimes if we build it up slowly over time, it can be sufficient to stop the activity of the ovary, so we can sort of shut off this activity. But I've still seen really good results even in women just on low doses on the patch, built up really, really slowly, just seems to sort of really reduce the I can't say that word, frequency and severity of their attacks. And I often see, and this isn't necessarily the case for everybody, but sometimes it's a combination of factors. So somebody is much more likely to get, some people are much more likely to get a migraine when their hormones are changing because of the change we talked about. But sometimes it's also, you know, their threshold is increased if they're also under stress, if things in their lifestyle aren't fantastic. So if we can just try and find a little bit more stability and reduce the frequency, it can really make a significant difference to quality of life. I've done video consultations with women who are, you know, feeling really unwell with their migraine, and seen them again, you know, a few months later, having built things up really gradually. You know, and it's had a really sort of transformative effect on, you know, their symptoms, ability to work, for example. I think with the progesterone, it's a little bit more, we have to think a little bit more, don't we? Because as we're wanting to avoid those sort of big changes in hormone levels, doing the usual sequential 2 weeks on, 2 weeks off of progesterone doesn't always work from a migraine perspective. hear
I'm
me.
not sure if Rachel, oh yeah, you just frozen. Yeah, you're
Yes,
there. Yeah.
doesn't
Yeah.
always work as well. So using a Mirena coil can be an excellent option just for delivering that really steady amount of progesterone into the system without those big changes. Sometimes using the progesterone like a Eutrodestin continuously, but that would be, there's a risk of irregular bleeding if we do that. So another really good option sometimes is using a progestogen off license, so maybe like the progesterone only pill, using that double dose as continuous, and that helps to stop the ovarian activity as well, doesn't it?
Yeah.
So we can reduce peaks and troughs that way. I'm also wondering whether things like SLIND might be an option as well, off
It's
license, but I've not used that yet
I
for
haven't
migraine.
used it either. I think, yeah, it's on the list of the British Menopause Society as an alternative progesterone, isn't it, for people who don't tolerate the other ones well. So I think, yeah, that there are definitely things, types of HRT that can be better for people who suffer from migraine attacks. And interestingly, it's helpful to try and, exactly as you said, go so slowly, isn't it? So rather than increasing the dose to try and manage the migraine, but to increase the dose slowly to manage the other symptoms as well. And what you said about lifestyle is so important. So things like exercising regularly, being very careful with your lifestyle, making sure that you eat regular meals with snacks, reducing caffeine, maybe some workplace adaptations, so to reduce stress. So looking at traveling to work and back, making sure you protect your mental health. Sometimes cognitive behavioral therapy can be quite good. And there are some supplements which are spoken about by in the national menopause, what's it called again, it's
The
gone out of my
national
head now. Hang on,
the National
National
Migraine
Migraine Centre,
Trust.
yes,
Oh,
has actually got some advice about what supplements to take. So vitamin D, coenzyme Q10, omega-3, magnesium, and vitamin B, is it 2, can
yeah, the
be riboflavin,
riboflavin. Yeah.
can be quite good. And she was, Dr. Katy Munro has done some talking about this and was saying you try some of them for 3 months, and that sometimes might also prevent migraine attacks. So I think if you're looking at it sort of in summary, your triggers, your acute treatment, get that really in sort of secure in your head. Preventive treatment if necessary, hormonal replacement therapy or the combined contraceptive pill in order to stabilize the hormones if things are worsening. Looking at lifestyle, looking at supplements, and some resources which are brilliant. So Dr. Katy Munro's written a book called Managing Your Migraine. And then there's we've written an article on migraine and hormones on the Rowena Health website, which you're very welcome to look at. And the National Migraine Centre, or the Heads Up podcast, is really good. You can learn an awful lot from that. And in fact, the National Migraine Centre offer consultations to patients as well. So it's really helpful to know if you're struggling with migraine attacks. And the British Menopause Society have written a document about HRT and migraine. So it's helpful for your GP to be able to look at what sort of things might work best, because certainly some things work best for some people and other things work best for others, don't they? It's the same, it's such an individual approach with all of us, isn't it?
Yeah, yeah. And I think another thing, I think you can download it on the National Migraine Centre, but I think you mentioned it earlier, but the headache diary, I think is really useful, isn't it? Certainly for us as doctors, but I think it's really useful as well, for patients to complete, because it
Yeah.
really helps to give an insight into what the patterns are. It helps, if we can work out when it's happening, particularly for younger women, when it's happening in the cycle. Are you somebody that's particularly triggered by those estrogen spikes, or is it more when things are dipping? Are there things happening in somebody's life that's triggering them? And it can just really help sort of just to notice, what's going on in your lifestyle, what's going on, maybe foods for some people, alcohol for some people, caffeine, like you mentioned. But it can really help, I think, empower people to notice what's affecting them and make changes accordingly, because otherwise it can feel really overwhelming. It's when you get that migraine, life is often busy. It's hard to think back as to what's been going on, but if you've got it written down, it can really help people. I've seen, people make, small changes, but have had a really impactful result just of having that written down, seeing the patterns and seeing the triggers. So I think you can download it on the National Migraine Centre website, can't you?
Yeah, I agree. And I think having the acute treatment really clear is also helpful. Some people I've seen, some young women who've actually found that they weren't able to go out, they weren't able to go to their social events, and actually work was becoming really difficult for them. And reading all the information that I've just sort of signposted to has meant that their life has entirely changed, and they've been so grateful actually for people to phone up afterwards and say that this has made such a difference to my quality of life. So there are definitely things that we can do to try and help, and help is out there for if you have even severe migraine. Even despite those, then I would say an appointment with the National Migraine Centre might be really helpful for you, unless your GP is very experienced at looking at migraine. But I think we've done well. We've covered everything that we wanted to cover. And we obviously have to say at this point, we talk really openly about the ways that we would treat conditions, because it's really nice, I think, to be able to share things in a bit more detail. But this is a chat between us both. So in order to find something that's going to suit you, you can't take this as guidance. You need to please go to see your doctor so that you can discuss any your own individual care with them. But by all means, listen to what we're saying and look at all the information that we've guided you to, because that can be really helpful in you creating a care plan with your GP or whoever it is that's looking after you.
Yeah, no, definitely. It's been great chatting, Carys.
Really good.
And
And we can upload it now to our so
yeah,
Rachel's been so kind upload it to our YouTube account where we're putting all these chats, because then it becomes easier for you to find them if you would like to listen again.
yeah, no, absolutely. And I'll pop the information about the resources when we've uploaded it to the grid and on the YouTube channel as well, so people can find those sites. So thank you so much to everyone who has joined. I hope you've enjoyed it as much as we have, and I hope you have a lovely rest of your evening. And if you've got any questions, you can let us know in the comments. And obviously you can find myself and Carys at Rowena Health, and on the Instagram page as well, which we'll tag. So thank you. Take care, Carys.
Lovely to see you. Take care. Thank you for listening. Bye.
Bye-bye.
Bye.
Bye.